Welcome. Thank you for selecting the breakout session on the importance of diagnostic and prognostic testing presented by Dr. Samir Shah. As a reminder, please feel free to enter your questions in the Q&A box at any time during the presentation. We are recording this session and the recording will be available post the webinar. So without further ado, I would like to invite our speaker, Dr. Samir Shah. He's a clinical professor of medicine at the Alpert Medical School at Brown University in Providence, Rhode Island, and chief of gastroenterology at the Miriam Hospital. He's a partner with Gastroenterology Associates, Inc., a private practice GI group affiliated with Brown. And the floor is yours, Dr. Shah.
Great. Well, thank you, Rishi. And I apologize for the technical issues. Although I live in Providence, Rhode Island, I'm actually in Corey Seagull country up in New Hampshire with my family, hoping that the kids enjoy some skiing. So that being said, next slide. And I noticed there's a lot of overlap between the talks here tonight. So I have no disclosures. Next slide. So my take-home points for this talk is we're going to talk about the delay between onset of symptoms and diagnosis. And unfortunately, even in 2021, there's still that delay in studies that can be months or even years. Hopefully that's becoming less frequent than it was in the past. We'll talk about prognostic factors that we understand and when we're considering how to treat somebody once we've made the diagnosis of Crohn's disease or ulcerative colitis. And there's an important distinction that we've come to think about in the last several years and in terms of disease severity versus disease activity. And I'll come back to that in a later slide. But disease severity kind of talks about the disease over time, whereas the disease activity is how you might be feeling now. So if I had a patient in front of me who felt well, but has had 4 surgeries and is feeling well right now because they just had their 4th surgery, that's a patient with severe disease, even though they feel well now. On the other hand, if I have a patient in front of me who's having frequent bowel movements and blood and diarrhea, but we know that for 20 years they've just had inflammation in the rectum, although they might be feeling not so good today and having disease activity that's active today, their overall prognosis and their disease severity is on the low side. We have clinical factors and we have other prediction tools. We're hoping to get better ones. We'll talk about that. You've already heard about treat to target, and I'm going to go into that in detail again, and precision medicine, which we hope to do. And basically all this means is customizing our therapy to fit you, and then discussing our goals. And for all our patients, we obviously want them to feel well, but we also want mucosal healing, both by endoscopy and increasingly by histology, because those things seem to translate to better outcomes. We want objective measures of disease because the symptoms aren't always accurate and they don't always reflect what's going on. So there can be people who feel really well and there's active inflammation going on the inside. And the idea is if there is a fire that's been put out, you want to make sure the fire is really out and not just rely on superficial things. We'll talk about quality of life because that's really important. And ways to measure disease. Endoscopy is still considered the gold standard, but it's not the most convenient thing for patients to have to go through a colonoscopy. It's invasive. There's imaging, and they've come a long way. I prefer MRI over CAT scan, especially in younger patients, to avoid the radiation risk, but CAT scans can be useful, and they've done things to reduce the radiation risk. And finally, we'll talk briefly about blood and stool markers of inflammation. I'm a big fan of one of the stool markers. It's much less invasive than colonoscopy, but not as convenient as a blood test. Next slide. So when we think about signs and symptoms that make us think about inflammatory bowel disease, diarrhea, bleeding, abdominal pain, weight loss, and in kids falling off their growth curve, abnormal labs are certain tip-offs, and you can have normal labs and still have IBD, but if we see elevated markers of inflammation like the C-reactive protein or SED rate, or in the stool fecal calprotectin, if somebody has anemia, particularly if it's iron deficient, and then other lab abnormalities, white count might be elevated. For most people, there's a gradual onset. For some people, there's a sudden onset when they have a complication like a perforation or an abscess. We'll talk briefly later on about silent Crohn's disease. And again, symptoms don't always correlate with disease activity, and therefore objective measures are really important to making sure we're achieving our goals. And Corey already talked about in his talk about the overlap with irritable bowel syndrome. It's unfortunate that IBS and IBD are just one letter apart. The symptoms can be similar, but they're clearly different diseases and they can coexist. So we want to make sure we're treating the right thing. Somebody with symptoms from irritable bowel syndrome doesn't need to be on a biologic. On the other hand, if there's inflammation ongoing, despite whatever treatment we're using, we need to address that. Referral to a specialist by your primary care provider can be helpful early on to make the diagnosis, and we'll consider colonoscopy and in certain patients upper endoscopy. Our pediatric colleagues will often do upper endoscopy with colonoscopy because they see more upper GI involvement in kids compared to adults, and they want to, if they're going to put a kid through a test, want to get all the information they can. Imaging, again, we focus on MRI and CAT scan, with MRI being preferred because of no radiation. And the inflammatory markers, we'll talk about fecal calprotectin. An important concept to think about when we're making the diagnosis is how extensive is the disease. In other words, how much of the intestine is involved, and then how inflamed is it? Is it mild, moderate, or severe? Next slide. So this is a very busy slide, and I just want you to understand that this is just about real estate and disease behavior. So we use something called the Montreal Classification, and it's pretty straightforward. Let's start on the right side of the slide with ulcerative colitis, because it's a little bit easier. With ulcerative colitis, if it's just the rectum that's involved, we call it ulcerative proctitis, and that's labeled in the Montreal Classification as E1. If there's inflammation on the left side of the colon, so that's the rectum and the sigmoid, but it's below where the splenic flexure is, that's considered left-sided colitis, or E2. If it goes beyond the splenic flexure, then a lot of the colon's involved, and it behaves like extensive or pan, meaning the entire colon, pancolitis. And patients with more extensive disease over time are at higher risk for both cancer and surgery, and it affects the way we consider treating them. If they just have left-sided disease, then topical therapies like suppositories or enemas can be very effective, either alone or in conjunction with oral therapies. With more extensive disease, topical therapy is not going to be enough to get people into remission. In terms of Crohn's disease, we break down in terms of age. So 16 or younger, A1, between 17 and 40, A2, and over 40, A3. And then depending on where the disease is. So if it's just ileal disease, meaning the small intestine, L1. If it's colonic, L2. If it's both the ileum and colon, that's the small intestine and the large intestine, which is the most common variety that we see of Crohn's, that's L3. And if there's upper GI involvement, we add a designation L4. And then we think about the disease behavior. Is it just inflammatory without any evidence of stricturing or penetration, meaning fistulas? Is it stricturing disease? And that would be B2. The non-penetrating, non-stricturing is B1. And is it fistulizing disease that forms abscesses? And that's B3. And that's the most aggressive. And we used to think 20, 30 years ago that there was ulcerative colitis and Crohn's disease that were very different. And we've come to realize now in 2021, there are over 200 genes associated with inflammatory bowel disease. And so that there are some genes that are more associated with ulcerative colitis, some more with Crohn's disease, but many of them overlap. And so you can understand that it's probably a disease spectrum, and some people fall more on the ulcerative colitis end of the spectrum, others more Crohn's disease. In about 10% of patients, we have a hard time deciding which it is, because they may have overlap things, and we'll call it IBD unspecified or undetermined. It's definitely IBD, but we don't know whether it's like Crohn's disease or ulcerative colitis. Next slide. So this is a summary of a nice review article that I point our medical students and residents and GI fellows to, that was published just this past December in the New England Journal of Medicine. It goes through our current understanding of the pathophysiology of inflammatory bowel disease. And we understand that it does run in families. There's certainly genetic factors. We said that already there are over 200 genes associated with IBD. We know that the microbiome, or the bacteria in our gut, have a huge influence. We're still figuring out what that influence is and how that interacts with genes. We know the immune system is very important, especially the gut immune system. And somehow that gets triggered and doesn't get turned off. And there are environmental exposures, things like NSAIDs, diet, smoking that can affect IBD. And all these factors come together to give us a picture of IBD. Next slide. So in terms of clinical prognostic factors, if we look at Crohn's disease, we know a younger age of diagnosis. If we see deep ulcers when we do a colonoscopy, if there's extensive involvement, not just a small amount of intestine, but a large amount of intestine, if there's severe rectal or perianal disease, if they've had a surgery already or several surgeries, and if they've had stricture and penetrating behavior, those are all risk factors for more aggressive disease, and also use of steroids early on. In ulcerative colitis, patients diagnosed at a young age, just like Crohn's disease, if they have deep ulcers, extensive colitis, if they have high high markers of inflammation like a CRP or sed rate or fecal count protected, if they require steroids, if they've been hospitalized, especially early on in their course, if they've had an infection like C. diff in addition to the colitis or CMV infection. Those are all risk factors for more aggressive disease. Next slide. So I'm just highlighting those. And again, obviously the opposite, if they've had limited disease and not those deep ulcers and older age diagnosis, they tend to do better. So how do we customize things to you? Well, if we're thinking about getting you off of steroids, and we don't like to use steroids, but sometimes we have to get things under control, there's an enzyme that metabolizes an immunomodulator that we use. There are two immunomodulators that are very similar, azathioprine and 6-MP. The body metabolizes azathioprine into 6-MP and gets metabolized further by several enzymes, including this enzyme called TPMT, or thiopurine methyltransferase. Now, most people, 90% of the population, have two good copies of that gene, but about 10% only have one copy. If we find that, then we have to dose reduce. And about 1 in 300 patients don't have that gene at all, and we shouldn't use azathioprine or 6-MP in those patients, because what will happen is they'll shut down their bone marrow and they'll end up needing a bone transplant. So we want to avoid that. So testing for that is very important. The other thing we can do is actually test for metabolites. So once we've done the TPMT testing and notice that they do have enzyme, they're on a steady dose, we can check for these metabolites. And the 6-TG metabolite, or 6-thioguanine metabolite, correlates with response. So a level of over 200 seems to indicate response. With 6-MMP, if a level is over 5,000 or 6,000, that seems to correlate with liver toxicity. So it's a good way of monitoring. There's also a new gene test that's been recently described, an HLA-DQA1, and that helps us figure out if somebody has a higher risk of getting antibodies to a couple of the anti-TNF biologics that we use, infliximab and adalimumab. So that hasn't caught on quite yet, but it's intriguing data, and we're just starting to consider using that to see if we're going to start somebody on infliximab or adalimumab, where they need to be on a second drug like 6-MP or azathioprine to prevent antibody formation to the biologic. And what being in New England, if I talk to my patients about this, I'll tell them that consider the biologic, whichever one. Let's just pick infliximab for the time being, is your Tom Brady. Then the 6-MP or azathioprine or methotrexate is your offensive line, keeping him around longer so that it works longer. Because if you develop antibodies to the biologic stops working. IBD serologies, these are antibodies that some patients develop that are antibodies to certain bacterial epitopes, can be seen in IBD patients. They're not used routinely because they're not accurate enough to diagnose the disease. So patients can have IBD and have negative serologies, and patients can have false positive IBD serologies. However, it's kind of intriguing that one of the serologies, P-ANCA, is more associated with ulcerative colitis, and some of the other serologies, CBER1, OMC, and ASCA, are associated with Crohn's disease. And several studies, both retrospective and prospective, have suggested that if you have more antibodies, especially the Crohn's disease ones, at higher titers, you tend to have more aggressive disease course. So that might help us predict disease course. And in fact, there's several commercially available testing panels, and I'm not endorsing any of these, I'm just letting you know about them, that might help a patient and a clinician figure out whether the disease is more aggressive or not when those other signs and things aren't there, or they just want more information. So there's IBDX from LabCorp, which looks at the diagnosis, disease type, and then has disease progression. There's Monitor, which is made by the company Prometheus, that looks at 13 biomarkers and has reasonable prediction in mucosal healing, so a non-invasive way to look at mucosal healing. And then there's a new thing, CD-Path, that Takeda bought, and actually was developed by my colleague Corey Siegel and Marla Dubinsky, and they combine serologies with NOD2. NOD2 is a gene associated with Crohn's disease and other clinical factors to predict the disease progression in Crohn's disease. And this is now available free thanks to Takeda. So we'll see if this is used more widespread and finds a place in us predicting. So it's no longer one size fits all. We try to customize the treatment based on your disease, but also based on your wishes and your concerns. Next slide. So if we're talking about somebody with more aggressive disease, then we start to think about biologics. And we used to sort of wait till somebody failed a lot of things before we moved to biologics. We realized that was the wrong approach. If we knew that they had aggressive disease, we knew those other drugs were not going to work. And if we move to biologics, if we use them earlier, they work much better. So now we try to have we don't try to delay. We call it appropriate aggressive early therapy. And so when we try to decide which biologic to use, we think about patient factors. Are they able to go for an IV infusion? Do they want a sub-Q? There's not biologics that are oral, but there are small molecule inhibitors that are PO or oral. We think about, what other things that a patient might have. Are they older? Do they have a history of cancer? Cost is certainly a huge issue. These are expensive medicines and basically unaffordable without insurance coverage. And navigating the insurance is really tough for all of us. We think about the disease factors, the phenotype, whether somebody's had surgery. We think about that disease activity versus severity. I'll come back to that. We think about, how good is the drug? What are our chances of response? And what about safety? Is it going to increase the risk of infections or cancer or other side effects? And with the biologics, the first drug that we choose usually works the best. So it's an important choice. It shouldn't be random. And it's a shared decision making. So this should be a partnership with your GI doctor to make sure you express your concerns. There's several great resources. Obviously, the Crohn's and Colitis Foundation has a wonderful website with useful information. And then there's a website that I like for my patients called ibdandme.org that goes over the information that I initially go over with them in the office visit, so they can do some more reading on their own about the various biologics, and they can put in their preferences. What's the most important thing to them? Safety? Is it efficacy? Is it speed of response? And that helps them help choose a medicine. And again, we talked about disease activity versus severity. Activity, how sick the patient is immediately. It's a snapshot, whereas disease severity includes elements of prognosis. So it's more of a long-term picture to see where things are going. Next slide. And when we think about Crohn's disease, but the same can be said for ulcerative colitis, it can be a progressive disease, and we only have a small window to get effective therapy on. If we don't, then that's inflammation leads to scarring, and then their therapies don't work as well. So we want to try to flatten that curve by getting patients who have aggressive disease on appropriate aggressive early therapy. Next slide. And you saw this before, and you'll see it again in some of the other talks, and it's the targets. And so back in the 1990s, when I was a medical student, resident, and fellow, we just cared about making patients feel better. If we got them feeling better and their symptoms are better, that was good enough. And then we talked about long-term remission, and then it wasn't good enough just to be in remission. You had to be off of steroids, thinking about all the side effects that steroids can cause. And then we realized that mucosal healing was important, and that if we could get mucosal healing, in other words, when we looked inside the colon, if it was healed, patients did much better. And the latest thing is histological remission. So even if there's healing in the mucosa, if we take biopsies and there's inflammation that the pathologist sees, those patients don't do quite as well as patients who achieve histologic remission. And Corey pointed out, although we want to try to get to these targets, sometimes perfect is the enemy of good, and we've got to decide when good enough is going to be okay. And that's a conversation to have, with your doctor, and to make sure we make it jointly. Next slide. So there's this sort of treat to target concept, and so we try to come up with a target together, make an assessment, and then make our choice on the medicine we're going to use. But then we shouldn't stop there. We need to reassess. And that sort of concept's been there for a long time in various diseases. For example, in diabetes, when somebody gets started on a diabetes medicine, you're going to monitor their glucose to make sure you're not overshooting or undershooting. Same thing with blood pressure, you're going to monitor that. So the same principle applies in inflammatory bowel disease, where we want to try to get to the right treatment. And then we're going to periodically monitor, and depending on how sick you are and how we can monitor, we'll figure out whether it's going to be every few weeks or every few months that we're going to monitor, or if you've been in remission for a long time, maybe yearly is enough. And it could be non-invasive with a fecal calprotectin, or it may be time for a colonoscopy. Next slide. So again, we want to get to these targets of no symptoms, so your quality of life is good, you feel well, and you're off of steroids, you're not on narcotics. We want to make sure that there's some sort of objective measure. It could be non-invasive markers like a CRP, if that gets elevated when you're sick. If it doesn't get elevated when you're sick, it's not a useful marker. Fecal calprotectin, I'm not a fan of that, is good, but it's not perfect. It's very good for colonic disease, so whether it's ulcerative colitis or Crohn's colitis, it's less accurate for a small bowel disease. We'll think about trough drug levels. So if we check the biologic level right before you do for your next dose, that's called therapeutic drug monitoring. There's data that suggests if we do that proactively, we can try to make sure that we optimize that drug from working the best. And we already talked about mucosal healing, but short of mucosal healing, there are other ways, including imaging with MRI or CT. Next. And then this is really important, that trust but verify. And so we want to trust your symptoms. We want to verify with something objective to make sure things are there. And as a father of teenage twins, that's my philosophy in dealing with them too. So I trust, but I need to verify. Next slide. So how do we choose again? Efficacy, safety, and that can incorporate somebody's age. And in older patients, I'm a little bit more worried about infections and cancer. Do they have a family history of cancer, or do they have a personal history of cancer? The cost, obviously, if we choose a medicine that is not affordable, that's not going to happen. And then positioning, which therapy should we choose? Because it does matter. So we want to choose the medicine that has the best chance of working. Do we need it to work very quickly because you're very sick in the hospital, or do we have the luxury of time? And then are you thinking about having a family? And so I proactively bring this up. And most of the medicines, fortunately, that we use in IBD are safe in pregnancy. And we've got great data to show that. We think about extraintestinal manifestations. So do they have other things besides colonic or small intestinal involvement, perineal fistulas, arthritis, skin issues like erythema nodosum, eye issues, or mouth ulcers, because certain biologics work better for those extraintestinal manifestations. Next slide. This is just a brief summary of the current biologics that we have in the USA, along with their trade name and their biosimilar. And you see we have infliximab, which was originally called Remicade, and then the biosimilars, and then with Inflectra and the others. Adalimumab, the biosimilars to those aren't currently available in the U.S. Golimumab, which is approved only for ulcerative colitis, Pegol for Crohn's. In terms of anti-integrin, natalizumab not used much because of side effects, and I won't get into that right now, but happy to answer your questions. Vedolizumab is used for both Crohn's disease and ulcerative colitis, and finally ustekinumab for both. Next slide. And I'm just finishing up. So the key thing here is the biosimilars seem to have the same efficacy and safety and the same assays. So although we don't like to make changes, the big advantage of biosimilars is they may reduce costs. So we're okay with a one-time switch, but the patient and the provider should be notified. We're not sure that multiple switches are safe, so we don't want to keep switching from one biosimilar to another to the originator product. Next slide. So there's a huge variation of biologics use in the United States, and this is data that was published. And the question is why? If somebody has active disease, shouldn't the rates be more similar? And we're trying to address this with CHORUS and other quality initiatives, so the right patient gets the right drug at the right time. Next slide. Keep going. And again, hopefully we can keep going. Yeah, we'll go through this to catch up. So this is just to show you some of the pictures we see in endoscopy. So normal, everything looks nice and pink, and we can see the blood vessels. Mild, the blood vessels are gone. Moderate, you can see it's more inflammation. With severe, there's spontaneous bleeding. And that mild, moderate, and severe correlates with a Mayo score that we use often of Mayo 0, 1, 2, and 3. And we're trying to get people back to Mayo 0 if possible. Mayo 1 may be okay for some people. Next slide. When we're talking about post-op recurrence, there's a scale called the Ruckteert score, named after Paul Ruckteert, who was a gastroenterologist in Belgium, and he developed this score. Next slide. And basically, when we look inside somebody's colon where they've had surgery and they've had part of their ileum and cecum removed and have an anastomosis, an ileoclonic anastomosis, if we look at the ileal side, we'll count the number of ulcers we see. If we see no ulcers or less than 5, that's a Ruckteert score of 0 or 1, and that correlates with a great response. If it's higher, those patients are likely to develop symptoms and relapse, so that we consider increasing therapy. And we usually do this 6 to 12 months after surgery to assess for recurrence. Next slide. So risk factors for colon cancer: the longer you've had IBD, if there's a greater extent of involvement, increased inflammation, both endoscopically and histologically, if you have a family history. If you have primary sclerosing cholangitis, which is a liver disorder, you're at a much higher risk and you need to get colonoscopies annually. If there are strictures, pseudopolyps, or a shortened colon, those are risk factors. Prior dysplasia, if you're male, you're at higher risk compared to females, and if there's been poor adherence or compliance with medical therapy. Next slide. So even if you're feeling well, we might do colonoscopies. So this is downloadable from the Crohn's and Colitis Foundation. There's one for adults and one for pediatrics. And this is just a healthcare maintenance checklist and goes over vaccinations and screening things we should do. And I find this very helpful. I hand it to all my patients. And this way, sometimes at the pharmacies, they get pushback at, oh, you don't need this vaccination. You're not old enough. Yes, I do. I have IBD and I'm on an immunomodulator or I'm on a biologic. So I qualify, and here's the reasons why. And hopefully that'll help patients get things done. Next slide. So fecal calprotectin, it distinguishes IBD from irritable bowel syndrome, can be used to monitor. It correlates very nicely with endoscopic findings. It's not perfect, but it's about 90% sensitive and specific in one large meta-analysis. And it usually rises before clinical relapse. So for whatever reason, if we stop a medicine and somebody's feeling well, we can use this to predict before they're going to relapse. It usually starts to go up about 3 months before. And so it can be useful in de-escalating therapy, in predicting post-op recurrence, in between scopes, engage response to new therapy. Next slide. And then you heard I'm a fan of MRI. This is a patient of mine who was started on an anti-TNF after surgery, and he didn't feel any different, but we showed him before and afterwards, and he's on the same medicine and continues to do well and has not had a second surgery. So this was very useful in convincing him that it was controlling his disease, although he didn't have a lot of symptoms. And he didn't have a lot of symptoms before he had his first surgery. Next slide. So we've gone over in a very short period that there's a delay still between onset of symptoms and diagnosis, that there are a bunch of prognostic factors, both clinical and laboratory factors and other prediction tools. We've talked about treat to target precision medicine. We've talked about mucosal healing and how that's so important to look at objective measures, not just symptoms. And we've talked about ways to measure disease. Next slide. Thank you. And sorry, I went a few minutes over with the technology issues with Zoom.
Thank you, Dr. Shah. That was very informative, and thank you for going through all of that. I know we had some technical difficulties at the beginning, but we just want to take a few minutes going over some questions. So I invite the audience to submit questions through the Q&A box. I know you did a really good job of answering some of those questions that were popping up, but I do see a few more here. The first one is if fecal calprotectin send rate CRP doesn't correlate well with remission or flare in some patients, like this this specific individual at anastomosis, are there any other biomarkers being investigated?
Yeah, so there are. So people are looking at a variety of inflammatory markers. The problem is exactly what that person is saying, is that it's not a one size fits all. So for one person, a fecal calprotectin or a CRP may be very good. For another person, it may not be. So we have got to find the right way to monitor you for your individual situation. And we want to be careful with using colonoscopy because, you know, although it's our gold standard, it's invasive, it's costly, and it does have the potential for complications. And, you know, you saw the MRE can be very useful too, but all of them, whichever you look at, have limitations. So the key is finding out which one works best for you. And in the meantime, hopefully with more cytokines and other inflammatory markers, we'll have better markers and be able to individualize it.
Great. And here's another question about how often to check UC histology or mucosal healing if the person feels okay symptom-wise, and how to check.
So I think, after, and I've changed my practice over time, and now I'm a little bit more aggressive. So if I have somebody newly diagnosed, I'm going to be on them fairly frequently to make sure they're feeling well. And then we have some sort of marker that they're in remission. And if it's the fecal calprotectin, let's say it was over 1,000 we started therapy and now they feel well and now it's normal, great. And then, after 8 years of disease, if they're at risk for colon cancer, we need to do a colonoscopy, not only to check the histology and make sure that they're in remission, but also for colon cancer prevention. So again, we've got to individualize based on your own risk for various things, and whether we need to be checking for polyps or cancer. And if the fecal calprotectin doesn't work for you, or it's not an accurate marker for you, then I think periodic scopes or other ways to monitor is reasonable.
I'll take 2 more questions here that I see in the Q&A box. At what level of antibody and drug level do you take a patient off infliximab?
Right. So that's the drug we have the most data on, and these days we're trying to shoot for an infliximab level at trough, meaning right before they do for their next infusion, of definitely above 5, and some people would say above 7. For patients with fistulizing disease, some people want a higher level too. In terms of antibody to the infliximab, depends on which lab you're using for the assay, because the different labs do it differently. But let's say you're using the Prometheus, and any of the labs are fine to use. What matters is what their standards are. And if there's no antibody, great. If there's low level antibody, you can often overcome that by increasing the dose and frequency of the drug and adding an immunomodulator, whether that's azathioprine, 6-MP, or methotrexate. If it's high levels of antibody to infliximab, you're not going to be able to overcome that, and then you have to change therapies. So if you're changing from infliximab and they're doing well and they're losing response because of antibodies, you could stay within class and switch to an alternate anti-TNF. But this patient's already shown you that they made antibodies to infliximab. So if you just start them on another anti-TNF without something else, then they're probably going to get antibodies to that. And so usually I'll have that discussion that, since you develop antibodies to infliximab, we should probably, if we're going to use, let's say, for example, adalimumab, we should use azathioprine or methotrexate in conjunction with that to prevent that from happening.
Got it. I gonna make this the last questions just in the interest of time, and just for the questions that we did miss, we'll try to create an FAQ document and send out responses on our end. But the last questionnaire here, how important is it to resume or maintain biologic therapy following surgery, such as an ileocecal resection?
Yeah, and I think, it's, again, this is where it's not a one size fits all. So if you've had disease for 30 years, you had your first resection and you were, 60 years old, I'd say you don't need anything. Don't go on anything right now, and let's scope you in 6 to 12 months and see if there's any disease recurrence. On the other hand, if this is your 4th or 5th surgery and you're younger, if we don't do something to prevent postoperative recurrence, we're fooling ourselves. So I think it matters the other circumstances around and what the disease course has been around that. And part of it depends on your preference too. And some patients, like, I don't want to go through another surgery. I want to do everything I can to prevent disease from coming back. So then we'll talk about lifestyle changes, avoiding NSAIDs if Crohn's disease, quitting smoking, and then probably the biologics are the best way to do that. And the most data is with the anti-TNFs, particularly infliximab, in preventing postoperative recurrence. On the other hand, if you're 70 and you've had your first surgery and you don't need to do anything, I think we'll just monitor, and hopefully you won't have to go on any medicine or have another surgery.
Great. Well, again, thank you so much for an educational evening. I think that has provided such valuable information for the IBD community. We would like to also thank, of course, our audience for joining us this evening. If you haven't already, before we say goodnight, we would like to invite you to view your local chapter's upcoming events on either the foundation website or their social media page. Each chapter has been very busy planning fun, creative, and safe ways for patients and their families to join us this year. So we hope to see you at an upcoming event. Also, please don't forget to fill out our evaluation surveys. We do take those very seriously. And for your convenience, the survey can be found in the chat box as well as in the post-webinar follow-up email we will be sending out. Again, thank you so much, Dr. Shah, and our audience, and we hope to see you at our next webinar in April.